everybody. The topic of discussion for today is inguinal canal. It is an oblique intermuscular potential passageway in the lower part of the anterior abdominal wall, just above the medial half of the inguinal ligament. It is roughly 4 to 5 centimeter long and larger in male as compared to females, reason being passageway of the spermatic cord. It is directed anteromedially and downward and serves as a passage for the structures which pass from anterior abdominal wall and the abdominal cavity to the external genitalia. It extends from deep inguinal ring to the superficial inguinal ring. Now the deep and superficial inguinal rings. First, the deep inguinal ring. It is an oval opening in the fascia transversalis about 1.25 centimeter above the mid-inguinal point, just lateral to inferior epigastric artery. It is strengthened above by arch fibers of transversus abdominis muscle and is larger in size in males as compared to females because it transmits spermatic cord in males as compared to round ligament in females. It gives a covering to the spermatic cord named as internal spermatic fascia. Second one is the superficial inguinal ring. It is an opening which is obtuse angle triangular gap in external oblique aponeurosis. Its base is about 1 centimeter and lies on the lateral part of the pubic crest. Apex is directed supralaterally and is strengthened by intercrural fibers. Medial crust is attached to the pubic crest and pubic symphysis, whereas the lateral crust is attached to the pubic tubercle and medial end of the inguinal ligament. Lateral, its length is 2.5 centimeter from base to apex, and spermatic cord passes through it, and this is the point where it can be palpated. Both the crura, that is external oblique aponeurosis, give a covering to the spermatic cord which is termed as external spermatic fascia. Inguinal canal boundaries are walls. Anterior wall is formed by aponeurosis of the external oblique, and lateral one-third is strengthened by the fleshy fibers of internal oblique. Roof is formed by arch lower fibers of the internal oblique aided by transversus abdominis muscle. Floor of the canal is the upper curved surface of the inguinal ligament and medially the lacunar ligament. Spermatic cord directly lies on this wall or the floor. Posterior wall is entirely formed by fascia transversalis and parietal peritoneum, whereas it is aided in its medial two-thirds by conjoined tendon and at its medial end by the reflected part of the inguinal ligament. Inferior epigastric artery is an important landmark that lies medial to the deep inguinal ligament. Inguinal triangle or Hesselbach triangle. It is a triangular area in the posterior wall of the inguinal canal, which is bounded below by the inguinal ligament, laterally by the inferior epigastric artery, and medially by the lateral border of rectus abdominis muscle. This is the site for the direct inguinal hernia and is divisible into two parts by medial umbilical ligament, which is the obliterated umbilical artery. These parts are lateral part between inferior epigastric artery and medial umbilical ligament, and medial part between medial umbilical ligament and lateral border of rectus abdominis muscle. Spermatic cord is a flexible cable or cord-like structure which is formed by ductus deferens and its accompanying structures. It extends from deep inguinal ring to the testes and is covered by a layer of serosa, the tunica vaginalis, which is an extension of parietal peritoneum. Components and coverings of the spermatic cord. First, the components. These are number one, ductus deferens, number two, testicular and cremasteric arteries along with artery of the ductus deferens. Number three, pampiniform plexus of veins. Number four, lymph vessels from the testes. Number five, ilioinguinal nerve, genital branch of genitofemoral nerve, and plexus of sympathetic nerves for ductus deferens. Number six, remnants of the processus vaginalis. As regard the covering, from within outward, these are number one, internal spermatic fascia derived from fascia transversalis. Number two, cremasteric fascia, a facial layer with cremasteric muscle loops derived from internal oblique muscle. Number three, external spermatic fascia derived from aponeurosis of the external oblique muscle. Inguinal canal is an area of weakness in the lower anterior abdominal wall. This weakness is compensated by a number of factors which are collectively named as mechanism of inguinal canal. Number one, oblique course of the inguinal canal. By increased intra-abdominal pressure, walls become approximated and produce a flap valve mechanism. Number two, superficial inguinal ring is guarded by conjugate tendon and reflected part of the inguinal ligament. Number three, deep inguinal ring is guarded superiorly by arching fibers of the transversus abdominis muscle. Number four, internal oblique muscle has got triple relation, that is anterior, superior and posterior. Hence, when it contracts, it produces a shutter-like mechanism, and transversus abdominis muscle may play a part or help this internal oblique in this action. Number five, contraction of cremasteric muscle pulls contents of the scrotum up and plug the superficial inguinal ring, producing ball valve mechanism. External oblique muscle by contraction leads to approximation of two crura of the superficial inguinal ring, producing slit valve mechanism. And this is also helped by intercrural fibers of the muscle. Number seven, hormones may be responsible for the maintenance of tone of the inguinal musculature. Now the development of the inguinal canal. Inguinal canal is actually a passageway for the testes and gubernaculum during development through the anterior abdominal wall. At start, the gubernaculum extends from caudal end of the developing gonads in the lumbar region to the labioscrotal swelling. In early life, canal is very short. With the passage of development and increasing age, as pelvis increases in width, deep inguinal ring is shifted laterally, and ultimately adult dimensions of the canal are attained. This whole process is accompanied by descent of the testes, which is divided into two stages. Number one, intra-abdominal stage, in which the gubernaculum, testes and the testes reach down to the inguinal region, whereas in the second stage, the extra-abdominal stage, the gubernaculum grows towards the scrotal swelling and ultimately makes contact with the floor of the scrotum. This whole descent of the testes process is a complex process and is attained through three steps. Number one, growth and elongation of gubernaculum causes intra-abdominal migration from lumbar region to deep inguinal ring. Number two, increase intra-abdominal pressure by rapid growth of abdominal viscera, especially the liver, pushes testes through the abdominal wall and causes the development of inguinal canal, and the gubernaculum and the testes reach the superficial inguinal ring. Now, with the development of the scrotum, number three, regression and contraction of the gubernaculum pulls the testes into the scrotum. Now we start with the description of the hernias. A hernia is a condition in which a part of an organ is displaced and protrudes through the wall of the cavity containing it. As regards the abdominal hernia, there are two main types. Number one is external hernia, in which a protrusion of any of the abdominal contents through any of its walls occurs. Whereas in the second type, the internal abdominal hernia, there is a protrusion of abdominal contents into no entry zone within the abdominal cavity. Now, a typical hernia parts. Hernia is a pouch with its contents and coverings, having a sac made up of peritoneum with a neck, a body, and a fundus. This sac contains small intestine, or omentum, or any of the viscera, and this sac is covered over by a layer of abdominal wall contents. Now the external hernias. There are so many types like inguinal hernia, indirect or direct, umbilical hernia, congenital hernia, or acquired infantile umbilical hernia. Para-umbilical hernia due to weakness in the linea alba around the umbilicus. Epigastric hernia, weakness in the upper part of the linea alba. Divarication of recti, weakness of the anti-abdominal wall, especially in multiparous female. Loops protrude during straining, such as cuffing, and return back. Incisional hernia due to weak surgical incision scar because of nerve injury. Lumbar hernia through the lumbar triangle in the posterior abdominal wall. Femoral hernia through femoral canal into the thigh. Now we start with the inguinal hernias. First, the indirect oblique inguinal hernia. It is protrusion of the abdominal contents through the inguinal canal, and the pathway followed by the contents is that they enter through the deep inguinal ring, which lies lateral to the inferior epigastric artery, pass through the inguinal canal, reach the superficial inguinal ring, or may reach the scrotum. Reason for this type of inguinal hernia is partial or complete patency of the processus vaginalis. Hence, it is more frequently seen in male infants and children. One characteristic of this type of inguinal hernia is that it has got a narrow sac. This is because of the fact that contents has to pass through the deep inguinal ring. This characteristics increases the chances of obstruction of the contents. As regard the coverings, from within outward, these are extraperitoneal connective tissue, internal spermatic fascia, cremasteric fascia and muscle, external spermatic fascia, and lastly the skin. Secondly, the deep inguinal hernia. It is protrusion of the abdominal contents directly through the weak posterior wall of the inguinal canal, that is in the area of triangle of Hesselbach. As the contents push directly through the posterior wall, this type of hernia has got a sac with wider neck. Hence, there are decreased chances of obstruction of the contents. This type of hernia, that is direct inguinal hernia, is divided into two types by medial inguinal ligament. First, the lateral type. Its covering from within outwards are number one, extraperitoneal connective tissue. Number two, fascia transversalis. Number three, cremasteric fascia. Number four, external oblique aponeurosis or spermatic fascia. And finally, the skin. As regard the medial type, the coverings are again extraperitoneal connective tissue, fascia transversalis, conjoint tendon, external oblique aponeurosis or spermatic fascia, and finally the skin. One thing to be noted is that there is difference between the lateral and the medial, is that in case of lateral, there is cremasteric fascia, which is replaced in the medial type by conjoint tendon. Now finally, the differences between indirect and direct inguinal hernia and their complications. First, the differences. Direct inguinal hernia occurs through a weak point in the posterior wall of the inguinal canal, that is in the area of Hesselbach triangle. As this is due to a weakness, so persistent increase intra-abdominal pressure can cause it. Whereas indirect inguinal hernia is due to persistent processus vaginalis. Direct presents as a peritoneal bulge, whereas indirect presents in the shape of a sac. Inferior epigastric vessels are present lateral to the direct inguinal hernia, whereas they are medial to the indirect inguinal hernia. Direct inguinal hernia has got no internal spermatic fascia, whereas indirect has got the this covering as it is derived from the fascia transversalis. Direct inguinal hernia usually occur in the adult age as it is due to weakness of the posterior wall of the inguinal canal, whereas indirect inguinal hernia is seen in the early ages as it is present because of processus vaginalis. Direct inguinal hernia has got less complication as this pushes directly through the posterior wall having a wider neck, whereas indirect inguinal hernia passes through the deep inguinal ring and has got a narrow neck with more chances of complications. These complications are: number one, irreducibility, that the contents cannot come back into the abdominal cavity, and this stage is named as irreducible hernia. Second is obstruction. If the distal part of the loop get swollen, then it is unable to revert back into the cavity and get obstructed. If obstruction prolongs, there are chances that arterial supply of the obstructive loop may be compromised. If it occurs, the loops may get necrosed. Comments and suggestions will be welcomed. Thank you for listening and watching.